guys. I'm excited to share this with you. It's one of the more impressive cases that we dealt with while I was doing my clinical pharmacy work. I'm not sure if I should say where, but it's probably obvious. Anyways, titled it Survival by the Milligram Amikacin TDM for extensively drug-resistant gut translocation. So these are some new terms for you guys. I'll explain it as we go along. This is very therapeutic drug monitoring centered, so pharmacokinetically centered. Yes. So what you need to know to understand the importance of this case and why it's something that's worth sharing, you need to understand the patient and the background first. So this is a 67-year-old white male from Zimbabwe, Rob Benengidi. He has acute myeloid leukemia. In other words, his bone marrow itself is not producing its white blood cells, red blood cells, and platelets that it needs to. But the reticulocytes, not really platelets. Platelets are produced by the liver. But anyways, but I mean, the blood cells are not being produced. So immunity-wise, he's got no immunity, and he's slowly getting worse. But to make matters worse, when you have leukemia, you need to undergo extensive chemotherapy. And you have to essentially destroy the bone marrow as it stands. So if you don't, there's a big chance of the stem cells from the donor being rejected, and then you have then you won't have engraftment, so you won't actually have success, and your bone marrow won't recover. So it's an important step in the treatment of leukemia. So you can't work around it. You have to undergo extensive chemotherapy, and you have to nuke the immune system completely. So unfortunate. So anyways, that's what we did for this patient. This also resulted in acute active mucositis. So mucositis is just your epithelial lining of your entire gastrointestinal tract becoming ulcerated and inflamed. So that's very important in this case because it explains a lot of what was going on. So he has no white cell counts, he has no immunity, and mortality in these patients can go up to 60%, even higher, as far as 70 taking place. So just to make things clear, here's a bit of a timeline for you guys. We started with this process in January, and all of our drama peaked from March into April. So from about the 4th of March, you can see there, let's just say it's the 1st of March until around 15 April, our drama peaked. So why am I saying that? Look at those white cell counts. Those white cell counts are essentially non-existent. So zero immunity, nothing. This patient has no immunity. And of course, that leads to infections on infections on infections on infections. So he had his first major life scare at 11 February, around about 18 February. Another one at about 10. Yeah, I don't know. There's a lot. You can see there's a lot of scares here. If you reach a CRP of above 50, that's a bacterial infection almost guaranteed. Remember, this patient lies still in bed. He's not moving anywhere. He's not getting amputated. He's not getting surgery. And the chemotherapy might to some extent contribute to this, but it might typically not to this level. And there's another reason why I'm quite confident that is the case. We also monitor the PCT for patients. So you can see those PCT spikes. There's 4 solid spikes. So on those 4 spikes, we can clearly see he was developing a bloodstream infection. And this is just nice quantitative evidence. But I mean, if you actually look at this patient, he was close to dying every single time. He was going hypertensive, he was going into shock. His renal functions went off, his liver functions went off, everything went off. He was absolutely at the edge of life. So it was a difficult balance. So how do you control all of this? Because you need to give him some immunity. How do you give him immunity? We use antibiotics. So we start typically as low as we can. Amoxicillin acid didn't work. He's still going into septic shock. Escalated piperacillin, tazobactam, and amikacin. Did work for a while. Then, so we once again decompensated. He went belly up again. And then we added linezolid. I'm not a fan of this idea. That's not my idea. It's a desperation of the hematologists. They were quite desperate. I probably should mention all of the people involved in this case. 3 hematologists, 1 medical officer, 1 microbiologist, 1 virologist, and his son, who was the bone marrow donor, was an orthopedic surgeon. And then, of course, me. Then, I'll show you guys the cultures in a second. But essentially, we had to escalate antibiotics every single time. The only real big change that I made here was changing these amikacin from 1 gram over 15 minutes daily to 750 milligrams every 6 hours over a 2-hour infusion. So if you go search for evidence, this is completely contrarian to all of the evidence you will find. All of the evidence says your patient needs to have a subtherapeutic level of Less than 0, less than 1 for at least 6 hours to protect his kidneys. That is what you'll find out there. But what's the point of dying with healthy kidneys? That was my thinking here. Like, we are so close to this, we need to do something. So, um, but first, we have to figure this out. Like, where are all these infections coming from? It's like, where are they coming from? And like, there's no wounds, there's no collections. It doesn't have anything weird, like any source that we have left behind and not found. It doesn't have any fibrotic tissue or scarring. Like some people have scarring in the lungs, and then they have like a abscess that envelops a bacteria there, and it can re-expose or like can exacerbate at some point. None of that. These got none of this. And we cultured it. We cultured and cultured and cultured and cultured it. Every single time there's a temperature spike or a CRP going up or a PCP going up, we cultured it. So we cultured him a total of 34 times. That's blood cultures, urine cultures, rectal swabs, you name it. We did everything we possibly could. And then we get to this graph, not graph, like this mess here. This is just all of the different bacteria that we cultured over time. And this is why I'm confident that it was gut translocation happening to this patient. So all of these bacteria at the bottom are Enterobacteriaceae. That means they are commensal organisms. That means they are part of you, like you have them in your gut at all times. But what happens if you use antibiotics, of course, is you select out the worst ones. So when we started with amoxicillin, we selected out this resistance pattern. And then when we added meropenem, we selected out a worse resistance pattern. And then when we used ceftazidime, avibactam, and aztreonam, we selected even a worse one. And then the last one, the one that was constantly coming back, was this Enterobacter clochaceae. I think that's the right name. And essentially, it was resistant against everything. Well, this was a desperate situation. So the hematologist called me, he called me after work hours, and because I made a suggestion in one of the meetings that we could try and import cefedricol. It's one of the antibiotics we haven't used in South Africa. So maybe this works. So let's import cefedricol. At least it's worth it on. But it's 250,000 rand for 7-day course. But the patient signed it off. He was happy to pay it. So we were that desperate. And then the microbiologist went back to the lab and did the test, and cefedricol resistance was already there. Like beggars belief. I couldn't believe it. So there was no options left. Like the only option was left is amikacin. You can see tigecycline is here, but tigecycline isn't an option because its volume of distribution is so massive that it can't actually achieve the right concentrations around any bacteria to kill it. And remember, the source is actively the gut. Like we can't decontaminate the gut. The gut will stay full of bacteria all the time. So we need to make the blood poisonous to these bacteria. But it's also important to understand why it works. And this is an easy explanation. So the organism's MIC was 2. And this patient was clearing amikacin much faster than normal. So his half-life was about 1.6, 1.7 hours, so very fast. Normal is about 3 hours, but you do get people with augmented clearance, so he had augmented clearance. So he would have reached subtherapeutic levels under the MIC of the organism, getting into the bloodstream from the gut the whole time, very early during the day. So he just didn't have coverage for the rest of the day. All of those other antibiotics that were added kind of gave him coverage, but it was not sufficient, it wasn't enough. And you saw the resistance profile that kind of explains it completely. Even if we went the old school route of TDS dosing, it wouldn't have been enough. This patient would still be subtherapeutic for some parts of the day. So we had to go double the normal maximum dose of amikacin, which in itself is a very scary thought, but it was the only way to keep his blood toxic enough for the bacteria not to enter and kill him. And it yielded good results. So this is initially, I use an application to do all of my pharmacokinetic calculations because it really is an intensive exercise to do all of these calculations. These are the things you learn in clinical pharmacy. We don't have time to teach you this in the undergraduate program. There's just not enough time. I wish there was, sorry, I really do. You can charge up to 840 Rand for a 15-minute consult and a report like this for a patient, and that's medical aid claimable. So it really is a worthwhile skill to have, and you can probably make a lot of money with it. But anyways, that's a route that we'll figure out how to pursue in the future. So initially his clearance was about 13 liters an hour, if I calculate correctly. In here it's 11, but at the time I remember 13 was closer to what I calculated. And so if we gave him a 750 milligrams QID, then we got this beautiful between 20 and 5, above the MIC all the time. And that was the only solution for him. You can see, like, if we did normal daily dosing, he would be below the MIC to around 10 hours in, so then he would get a reinfection. And that was evident from all of the previous PCT and CRP spikes that I showed you. So evident, very evident. Okay, but the real big question remaining now is, how do we double the normal safe dose of amikacin, which is nephrotoxic and ototoxic, and how do we not get these toxicities? So we tested for the ototoxicity. There's a pharmacogenomic test you can do. It's part of the mitochondrial DNA. You have to have some kind of a mutation there. You didn't have it, so we were safe ototoxicity-wise. Magic, fine. And nephrotoxicity-wise, we did get an acute tubular necrosis from the amikacin. Around the 15, because remember, the most important thing about doing TDM and clinical pharmacy is monitoring. So around about the 15th of April, we were repeating levels the whole time just to be on the safe side. So around about the 15th of April, I calculated his clearance had actually dropped 70%. So once the acute tubular necrosis starts, once the amikacin metabolism has been saturated. So in other words, he wasn't able to clear amikacin the same speed anymore because he's reached acute tubular necrosis. So at that stage, we could reduce his dose to 500 milligrams 3 times a day, just because his body is clearing it slower now. So his half-life went around from 1.6 hours to 4.5 hours. So there's a huge difference. So we decreased his dose and we carried him on that dose with that tigecycline as well up until the 24th of April. And then on the 24th of April, he engrafted. So his white cell counts went up and finally had an immunity again. So we didn't have to continue with this risky business anymore. But also interestingly, if you wanted to diagnose this acute tubular necrosis, you would never have been able to with the typical clinical guidelines. The typical clinical guidelines, you need a increase in serum creatinine of about 25% over X amount of time, and that never happened. It never happened. But I know he had acute tubular necrosis based on the pharmacokinetics, and there's another one. He ended up with magnesium wasting, so we had to give him 6 grams of magnesium per day just to carry him through towards the end. So he definitely did get acute tubular necrosis, but at least that's completely reversible. And remember, he didn't die, so it's pointless dying with good kidneys, and that's the case, more or less.